بسم الله الرحمن الرحيم. الله يعطيكم العافية. محاضرتنا اليوم عن chronic inflammation، وراح نحكي عن a definition of a chronic inflammation. The chronic inflammation is inflammation of prolonged duration, weeks, months, or years, that starts either rapidly or slowly. Chronic inflammation characterized by an equilibrium of persistent injurious agents and inability of the host to overcome the injurious agents. So it means the tissue injury and attempts at repair coexist in varying combinations. In contrast to acute inflammation, which is manifested by vascular changes, edema, and predominantly neutrophilic infiltration, chronic inflammation is characterized by infiltration with mononuclear cells, which include lymphocytes, plasma cells, and macrophages. Tissue destruction induced by the persistent offending agent or by the inflammatory cells, and attempts at healing by connective tissue replacement of damaged tissue, accomplished by perforation of small blood vessels. It's called angiogenesis, and in particular fibrosis. This is the difference between acute inflammation and chronic inflammation. In acute inflammation, the duration between minutes to days, whereas in chronic inflammation, days to years. The predominant cells in acute inflammation are neutrophils, whereas in chronic inflammation, the predominant cells are lymphocytes and macrophages and plasma cells. Acute inflammation characterized by fluid and plasma protein oxidation, whereas chronic inflammation characterized by vascular perforation and fibrosis. So this is the difference between chronic and acute pneumonia. This is in the left side. This is a chronic inflammation in the lung, showing all three characteristic histologic features, including collection of chronic inflammatory cells, destruction of parenchymal lungs, including normal alveoli replaced by spaces lined by cuboidal epithelium, and replacement by connective tissue or fibrosis where the arrows are. In contrast, in the right side, there is acute inflammation of the lung, which is called acute bronchopneumonia. There is a neutrophilic infiltration, fill the alveolar spaces, and the blood vessels are congested. Chronic inflammation, under what circumstances there is a progression from acute inflammation, for example, tonsillitis or osteomyelitis, or repeat exposure to toxic agents such as silicosis, asbestosis, or hyperlipidemia, or could be chronic inflammation developed from viral infections or persistent microbial infection such as mycobacteria, treponema and fungi, or chronic inflammation induced by autoimmune disorders such as rheumatoid arthritis, SLE, which is systemic lupus erythematosus, or systemic lupus. The macrophages is the dominant cellular player in chronic inflammation. The mononuclear phagocyte system, sometimes called reticuloendothelial system, consist of closely related cells of bone marrow origin, including blood monocytes and tissue macrophages. The macrophages are diffusely scattered in the connective tissue or located in organs such as the liver. The macrophages in the liver called Kupffer cells, in the spleen and lymph nodes called sinus histiocytes, in the lung called alveolar macrophages, and central nervous system called microglia. The monocytes, when activated mainly by interferon gamma secreted from T lymphocytes, the monocytes will increase in size and lysosomal enzymes, and the monocytes will be more active in metabolic, for example, greater ability to kill ingested organisms, and the monocytes will be epithelioid in appearance. This is the pathways of macrophage activation. Different stimuli activate monocytes slash macrophages to develop into functionally distinct populations. There is classically activated macrophages, which are induced by microbial products and cytokines, particularly interferon gamma, and are microbacterial and involved in potentially harmful inflammation. Alternatively, activated macrophages are induced by interferon 4 and interferon 13, produced by T cell helper 2, which is a helper T cell subset, and other leukocytes, and are important in tissue repair and fibrosis. How do macrophages accumulate at site of chronic inflammation? So the recruitment of monocytes from circulation by chemotactic factors such as chemokines, C5a, platelet-derived growth factor, tumor growth factor alpha, fibrinopeptides, fibronectin, collagen breakdown fragments, and the proliferation of macrophages at foci inflammation and immobilization of macrophages at sites of inflammation. The products that activated macrophages, including proteases, complement and clotting factors, oxygen species and nitric oxides, arachidonic acid metabolites, interleukin 1, tumor necrosis factor, and growth factors, including platelet-derived growth factor, fibroblast growth factor, and tumor growth factor beta. The role of activated macrophages in chronic inflammation. The macrophages may be activated by a variety of stimuli, including microbial products that engage toll-like receptors and other cellular receptors, cytokines such as interferon gamma secreted by sensitized T lymphocytes and by natural killer cells and other chemical mediators. Macrophages are activated by non-immunologic stimuli such as endotoxin or by cytokines from immune-activated T cells, particularly interferon gamma. The products made by activated macrophages that cause tissue injury and fibrosis. Uh, Lymphocytes and macrophages interact in a bi-directional way, and these interactions play an important role in propagating chronic inflammation. Macrophages display antigen to T cells, express membrane molecules called costimulator, and produce cytokines such as interleukin 12 and others that stimulate T cell responses. Activated T cells or activated T lymphocytes in turn produce cytokines which recruit and activate macrophages and thus promote more antigen presentation and cytokine secretion. The result is a cycle of cellular reactions that fuel and sustain chronic inflammation. So this is the complete resolution inflammation. So when the circulating monocytes become mature and become a macrophage, then the macrophage produce growth factor and induce new blood vessels, and then replaced by fibrosis, which is called repair by fibrosis. Let's move to the granulomatous inflammation, which is a distinctive form of a chronic inflammation that characterized by collection of epithelioid histiocytes. Um Granuloma, in addition to epithelioid macrophages, may have one or more of the following: surrounding rim lymphocytes and plasma cells, and surrounding rim of fibroblasts and fibroses. The granuloma may contain multinucleated giant cells and central necrosis, which is called caseating granulomas, particularly in tuberculosis. This is the granuloma, consisting of aggregates of macrophages that are transformed into epithelial-like cells surrounded by a collar of mononuclear leukocytes, uh, particularly lymphocytes and occasionally plasma cells. This is the granuloma that have Langerhans type giant cells or multinucleated giant cells. This is a typical granuloma resulting from infection with mycobacterial or mycobacterium tuberculosis that show central area of caseous necrosis. Activated epithelioid macrophages and a peripheral accumulation of lymphocytes are present here in this section. This is the a prototype of the immune granuloma, uh, is caused by infection with Mycobacterium tuberculosis. This is acid fast stain for tubercle bacilli, which is in a red or uh, um, red in color, or which is pink or red in color. So these are the examples of granulomatous inflammation. So in the left side, this is the causative agents that cause granulomas. For example, bacteria can cause granuloma. For example, Mycobacterium tuberculosis, as we said in the last uh, slides, Mycobacterium leprae, Troponema pallidum, Bartonella henselae. Parasitic infection can cause granuloma such as schistosomiasis. Fungi, for example, Histoplasma capsulatum, plastomycosis, Cryptococcus neoformis, or Coccidius immitis. Inorganic metals such as silicosis or berylliosis. Foreign body, suture, or other prosthesis, keratin, or unknown cause such as sarcoidosis. The morphologic appearance of chronic inflammation include ulceration. The ulcer, it's a local defect or loss of the continuity in surface epithelium. Chronic abscess cavity, induration and fibrosis, thickening of the wall of a hollow viscous or caseous necrosis. So these are the whole morphological appearance of a chronic inflammation. Let's move to the systemic effects of inflammation, or what's called acute phase reactions. Anyone who has suffered a severe bout of viral illness, such as influenza, has experienced the systemic effects of inflammation, called acute phase reaction, or the systemic inflammatory response syndrome. The cytokines, tumor necrosis, and interleukin 1, interleukin 6 are the most important mediators of the acute phase reaction. These cytokines are produced by leukocytes and other cell types in response to infection or in immune reactions and are released systemically. Tumor necrosis factor and interleukin 1 have similar biologic actions. Interleukin 6 stimulates the hepatic synthesis of a number of plasma proteins. The systemic manifestations include fever, catabolism, increases slow wave sleep, decreased appetite, hypotension, and other hemodynamic changes, synthesis of acute phase proteins by liver, C-reactive protein, fibrinogen, serum amyloid A protein, leukocytosis or neutrophilia, lymphocytosis, eosinophilia, leukopenia, which means low white blood cells and increase ESR, low erythrocyte sedimentation rate. This is the picture that show a systemic acute phase reaction, which is induced by multi-organs, including the hypothalamus, the adrenal cortex, liver, and bone marrows. The consequences of defective inflammation is susceptibility to infectious, such as defective innate immunity or delay in the repair system, which include the delayed clearance of debris and necrotic tissue and lack of stimuli for repair. So the consequences of excessive inflammation include allergic reactions, autoimmune disorders, atherosclerosis, and ischemic heart disease. Now let's move to the tissue repair. Dr. Saib Al-Khatib will explain and give you the whole details about the tissue repair. Uh, Now we will just give you an introduction about the tissue repair. So repair, sometimes called healing, refers to the restoration of tissue architecture and function after an injury. It occurs by two types of reactions: regeneration of the injured tissue and scar formation by the deposition of connective tissue. So this is the mechanisms of tissue repair, regeneration, and scar formation. For example, if you look to the left side of the picture, you will see that after mild injury, which damages the epithelium but not the underlying tissue, resolution occurs by regeneration. But after more severe injury with damage, for example, in the right side of the picture, uh, when we have severe injury with damage to the connective tissue, the repair is by scar formation. So this is the repair, regeneration, and fibrosis after injury and inflammation. So if you look to the left side, when we have that the stimulus removed in acute injury, so the repair will occur in two ways. If we have the parenchymal cell death or superficial wounds and some inflammatory processes, so the healing will occur in regeneration or restitution of normal structure. For example, when we have liver regeneration after partial hepatectomy, or superficial skin wounds, or resorption of exudate in lobar pneumonia. If we have a deep wound or that the parenchymal cell death damaged tissue framework, the repair will be by healing or scar formation or organization of exudate. For example, when we have deep excisional wounds or myocardial infarction. If you look to the right side of the picture, if we have persistent tissue damage, the repair will occur in a fibrosis or tissue scar. For example, when we have chronic inflammatory diseases such as cirrhosis, chronic pancreatitis, or pulmonary fibrosis. So the two processes of repair, including regeneration and fibrosis. Regeneration, some tissues are able to replace the damaged cells and essentially return to a normal state. This process is called regeneration. Regeneration occurs by proliferation of residual or uninjured cells that retain the capacity to divide, and by replacement from tissue stem cells. It's the typical response to injury in the rapidly dividing epithelia of the skin and intestines and some parenchymal organs, such as in the liver. The scar formation, if the injured tissues are incapable of regeneration, or if the supporting structures of the tissues are severely damaged. Repair occurs by uh, laying down of connective or fibrous tissue, a process that results in scar formation. Although the fibrous scar cannot perform the function of lost parenchymal cells, it provides enough structural stability that the injured tissue is usually able to function. The term fibrosis is most often used to describe the extensive deposition of collagen that occurs in the lung, liver, kidney, and other organs as a consequence of a chronic inflammation, or in the myocardium after extensive ischemic necrosis. If fibrosis develops in a tissue space occupied by an inflammatory oxidate, it's called organization, as in organizing pneumonia affecting the lung. So the healing is a combination of regenerative and fibrotic processes. The proliferative potential of different cell types. The ability of tissues to repair themselves is critically influenced by their intrinsic proliferative capacity. The tissues of the body are divided into three groups: labile or continuously dividing tissues, uh, that it means the cells of these tissues are continuously being lost and replaced by maturation from stem cells and by proliferation of mature cells. Stable cells or stable tissues, cells of these tissues are quiescent and have only minimal replicative activity in their normal states. However, these cells are capable of proliferating in response to injury or loss of tissue masses. For example, liver, kidney, smooth muscles. And the example for labile cells, skin epidermis, as we said, GI tract, bone marrow cells. The third cell type is permanent tissues. It means the cells of these tissues are considered to be terminally differentiated and non-proliferative in postnatal life. Most neurons and cardiac muscles cells belong to this category. This is the mechanism regulating cell population. Cell numbers can be altered by increase or decrease rates of the stem cell input, cell death due to apoptosis, or changes in the rate of proliferation or differentiation. So this is the cell cycle landmarks. The figure shows the cell cycle phases. For example, G0, G1, G2, S, and M, the location of the G1 restriction point and the G1S and G2M cell cycle checkpoints. Cells from labile tissues, such as in the epidermis and GI tract, may cycle continuously. Stable cells, such as hepatocytes, are quiescent but can enter the cell cycle. Permanent cells, such as neurons and cardiac myocytes, as we said, have lost the capacity to proliferate. والله يعطيكم العافية. إن شاء الله دكتور صهيب بكمل معكم.